Hi, I'm Ralph Preston, and on Tuesdays we have these Stroke Buddies Recovery and Science Zoom meetings. And today we've got back for the fifth time my friend Tom Haynes. Tom's a NeuroPT in the UK, and he's blessed us with his knowledge four times previously, and always full of good information. And today we're going to talk about gait, post-stroke, and about how we might all walk better. And as stroke survivors, I'll tell you what, that's that and our hands are the number one and two things on our list of things we're concerned about. So, Tom, thank you for coming. I know it's 9 o'clock at night for you. I appreciate you uh, taking time out of your schedule to talk to us. So,
No
uh,
worries, and thank you for having me back again. I really enjoy doing these podcast events, and don't worry about the time. I'm a bit of a night owl, and I've got coffee to see me through.
well, you're all set if you got coffee.
I got coffee, yeah. So the first thing that is important to note is that improving walking is different for everyone after a stroke because we have different severities of stroke, and there is a certain um, level of impairment that people will have. So not
Mhm,
everybody is going to start on the same square. Some
mhm,
people will have mild impairment that affects only one part of the leg, for example. Meanwhile, other people will be fully affected down one side, limbs, and potentially also their trunk and back, which means that we're going to have to start from a more basic level. Um, to cover progression from each of those different starting points is something that I'd love to go through, but we're not going to get done in an hour. But what I would like to do is discuss what I've kind of listed as 8 principles of improving walking based on what we know from a neurorehabilitation theory. And it's a mixed approach. So, as we've discussed before, Ralph, we've got different schools of thought when it comes to neuro rehab, and it varies dependent on whereabouts you live. So, without going too much off piste here, in the States and particularly in the UK as well, we subscribe a lot to the NDT, the neurodevelopmental therapy approach, or what we call BOBATH. Um, you guys tend to do a lot more of something called PNF as well. We don't tend to do much of that over here. We do it, just not as much. Meanwhile, if you move across to kind of the Scandinavian countries, they've got a concept called Brunnstrom, and and then kind of smattered around Europe, including the UK. I'm not know too much about in the US. We've got something called movement science therapy as well. So the idea is that there isn't one set approach that's going to work, and what we need to do is use them each as tools towards adopting these principles to make your walking better. So I won't go too much into the theory of it, and we'll just kind of take each principle as it comes, okay? And then we can kind of go from there. Um, so the first thing I listed to improve walking is the principle of improving range of movement. Um, Now, the reason why this is important is that when we've had a stroke, we don't only lose what's called your active range of movement, your ability to turn on your arm or turn on your leg the way that it was intended, but even within a few days to weeks, you'll start to notice that you'll lose passive range of movements as well. And that can be as a result of not moving. So you get joint stiffness, you get um, muscle contractures start to develop, and you also get the emergence of, in most cases, some unwanted kind of high muscle tone, some spasticity or rigidity. Um, so what we want to try to always adopt as part of improving walking and balance, any of those things, is having a ability to increase and maximize the freedom of movement that we have down our affected side. Because much like when you set foundations to kind of build a house, if you don't have a nice leveled out ground, a nice leveled surface, whatever we build on top of it is going to be wonky. It's not going to be effective. So the first thing to bear in mind is to look at your limbs. find out what range of movement you have got access to, what range of movement you haven't, whether it's by weakness or by stiffness or spasticity. And if it's due to the latter, the spasticity element of things or the tightness, employ a series of active assisted stretches. And if you've got someone that's able to support you, some passive stretches in order to prep the body effectively to do standing, to do walking. The brain is in a state all the time following a stroke, more so at the start, where it wants to, in response to the inflammation and damage, it wants to rewire itself as best as it can around that site before we get scar tissue that develops. And so, giving the most fluid foundation to do therapy is going to ensure that when possible, we're getting the best improvement we can. Um, and even if it's not early on, it still applies to chronic strokes because with you guys that have had spasticity for months or years, if we're still trying to better our walking, if we can try to minimize the impact of that when we attempt to do voluntary movement, that's only going to be better for all of us for learning improved ways of doing the walking and making it more efficient. So range of movement is one thing, and what I wanted to do with each principle is kind of open up with any questions people have about each principle, really. So I can expand upon it. So it's not just me talking at you for an hour. So I just wonder if anyone around range, whether that's how it might affect us, what can we do, what examples have you got, anything like that. Is there anything anyone wants to ask me about that principle?
Yes, can I? It's Tom. Do
Hi,
you know
Chris.
me?
Yeah,
Hi.
I
Yeah.
recognize you. Yeah.
Um, I've got a very tight and atrophied calf, and so at the moment I'm trying to build it up with a bit of eccentric stretching.
Yes.
Um, Now I take it that because I get tightness in the calf, it's okay to build the muscle, is it?
Yes. I mean, there's two ways of thinking about this. So when you've had a stroke that affects the voluntary pathway that impacts your leg, you most often have particular patterns that will emerge first, most commonly uh, in your quadriceps, in your thigh muscle, and in your calf will become more spastic and overactive. So having things like clonus, having spasticity in the calf is very, very common. And you're right to try and address it because if we don't have that range of movement, then we have the spasticity in the calf can cause other problems such as knee overlocking. So when the knee snaps back when we stand on it, when we stand on the affected leg, what's called hyperextension. The other thing is we can simply trip because we're not clearing the floor effectively because of that calf spasticity. And then the other thing is that we're not able to transition smoothly from putting our foot down to carrying our weight forwards because the calf will be stopping that natural weight transition. So there's three ways that tight calf is going to impact walking for the worse. So as part of that range of movement principle, addressing that is going to be key towards bettering your gait quality. So eccentric stretching, I imagine that's stuff like dropping heel off the edge of a bottom step of a staircase. I imagine something like that
That's
is a
right.
really, yeah, it's a really effective way of employing that stretch and maintaining it. What we want to ensure is we do that slowly. The principles of spasticity is it's dependent on speed. So speed of movement often makes spasticity catch or respond. So we want to make sure when we're doing stretches with muscles that have spasticity that we're elongating at a very, very slow rate so that we don't get that reactive high tone that's going to fight against us to stretch. Um, Making sure that we are not causing pain through the base of the foot when you do it is going to be important as well for the same principle of not encouraging more spasticity. But weight bared eccentric stretching is the best way of doing that because if we can encourage gradual loading, what it's called, on the tendons, on that big tendon on the back of your calf called your Achilles, then we get this inhibitory effect in the spine that will help to if you hold the stretch, suppress the activation of the spasticity and you'll get greater length. So doing that in that way is really useful. Um, the only other effective means of doing such a thing is if you did have access to the front muscle on your shin, your what's called your tibialis anterior, the ability to lift your toes and lift the top of your foot up. Most people do lack that after a stroke. But if you're very fortunate to have use of that, then one of the really effective things you can do during an eccentric stretch or during any calf stretch is to try to actively use the front of your shin by pulling up your foot whilst you're stretching, because there's this natural, what's called reciprocal inhibition effect, where when you activate the one muscle, the other one will relax neurologically. So there's a couple of principles. Yes, slow stretching, weighted stretching, and trying to work the muscle that's opposing the movement you're trying to stretch.
Thanks. I do have access to my tibialis.
Good. So that's something that you can try and increase as part of your stretching
Mm.
protocol and see how that goes.
Yeah, thank you.
Thanks, Chris. Was there anyone else that had a question about range of movement? And if not, I'll just kind of move on to the next bit.
I have a quick one, hopefully.
Sure.
I do not have spasticity. However, I experience now in my affected side a complete diminishing of anything that would signal stop in a stretch.
Do you mean you don't have a sensation of the affected side?
Correct. So my stroke was below the basal ganglia on the right, and so my left side I find now is longer. It has obviously it's losing muscle tone, but I have motor ability.
Yeah.
Sensory is a little weird, but I never hurt when I stretch on the left the way that I do on the right.
Yeah.
So I have the obvious concern of injuring myself. So I'm
Mhm.
wondering if there's anything else that I can kind of be aware of when I would say do a calf stretch. I keep a yoga block by my
Yeah.
sink in the morning so that I can stretch my calf, and I experience pain on the right hand side and nothing on the left if I go very, very far.
Yeah. I know that's a really thank you for sharing that with me, Stephanie, as well, because I know it's hard to talk about, how stroke affects us. And having a sensory deficit with full motor control, or, a great deal of motor control, is a more uncommon variant that we see. Um, However, there are ways to navigate around that by accommodating what you can see. So when you're doing a stretch, you will feel in your unaffected side the level of tension build up, and you'll get that natural pain response. If you don't get that in the other side, you need to use other sensory points to understand how far is normal for that calf to go. Whilst we do have subtle asymmetries in our body, it's important to note that most joints will have a natural limit that they'll want to go to, and muscles will as well. And if you have got a normal side and you can see how far that goes before it becomes a problem, then you've got a target that you're trying to move towards in terms of not overstretching the other side, because you'll see what is naturally a normal range, and you can see when you're stretching if you're developing. Do you get any indication of resistance that's developing anywhere?
Actually, I sometimes in my hamstring will get that kind of spastic, you've gone too far kind of thing, but that's really the only.
Yeah, I think if you can put your foot up on a block to stretch without your heel lifting off and with you maintaining an upright posture leaning forwards, that is more than enough range of movement within that calf. There's no need to gain any more, because unless you're doing a specific activity that requires that excessive degree of motion, I would say that there's more than enough there. And just use what's a normal range on your unaffected side as a reference point. And exercise caution, when you're doing that.
Great. Thank you so much.
Could
No
I
worries.
could I say something? Oh, this is Bruce Hetzler. I'm
Hi,
sorry to
Bruce.
interrupt here. I'm not a physical therapist or occupational therapist. I'm a retired college professor, so I have no clinical experience. But Stephanie, you mentioned that you had a stroke in your right hemisphere below your basal ganglia. Is that correct?
Correct.
And I'm not trying to be too personal, but how long ago was your stroke?
Almost, it will be 2 years this October.
Okay, the reason I'm asking this is that a stroke in the right hemisphere in the parietal lobe, which I think is roughly where yours is, will sometimes produce unilateral neglect. That is, you will tend to ignore things on the left side of your body. And that may mean you will have a loss of sensation, or you're not blind there, but you will tend not to pay attention to things on the left. Now, I had a stroke 14 years ago, and initially, for a year or two or three, because of the location of mine, I had some of this unilateral neglect on the left side of my body. So if someone touched my left arm, I couldn't feel that, for example. Now I can. So this unilateral neglect can sort of go away. That going away is accelerated the more you use that, use your left hand and so on. And if you have a sensory deficit, I don't know if you have problems feeling something, then
Yes, I do.
okay, touching things of various textures can help. You can retrain your left hand or left arm or something by touching like a silk versus sandpaper versus a rock or something.
Hmm.
So this is not directly related to movement, so I guess I should just sort of shut up now, but this might be something that is affecting it.
Well, thank you for the encouragement. I also notice that when I'm taking things out of the microwave, like I can touch the dish with my left hand, but not with my right and so obviously I have to be kind of aware of the dangers, like you were saying, Tom, just stretching too far and yeah.
I'll just chime in for just a sec, and we'll just kick it back to Tom. One thing I did when I did my calf stretches was I did them on a set of steps with railings on both sides. You can move either left or right, so that you can hold on with your unaffected side if you need to for safety. The thing about doing heel raises on a step is you can also do heel dips if you're on your toes, and you can control how much of that toe comes up.
Yeah.
Now you are putting your weight into it, so you have to be you have to have some muscle control and be a little aware of how far you're dipping. But on the steps, you have a lot of control, and it turns a heel raise into a toe raise if you dip below the level of the step. So
Yeah. And Ralph, that's what you've described, which is similar to what we discussed with Chris, is the most effective way of doing that. Because if you've got good enough calf use, this is the caution with this though, is you've got to make sure that when you do the heel raises, that your foot is not turning inwards excessively. If you can do it without that, then activating the muscle you want to stretch submaximally, for about 8 to 10 seconds will generate what's called an autogenic inhibitory effect, where when you then go to oppose it and go the opposite way, it will naturally neurologically relax more. Then you load it eccentrically, building up further inhibitory pressure. And then when you use the other side, the toe up actively, you further deepen the stretch. So what you've discovered by yourself is actually this principle of what we call PNF stretching. The technical term is yeah.
who knew?
You may have heard it before, something called hold, relax, agonist, contract.
Yeah.
Yeah, that's kind of what you're describing. And it's actually post-stroke, the most effective way of stretching any limb is to contract the muscle you want to stretch. If you can activate it voluntarily, sustain the contraction, then oppose it in the opposite direction to load the stretch slowly with weight, and then you use the muscle on the opposite side to further encourage the stretch. So yeah, that is the
Can
evidence
you
best way to do
repeat
it.
that just so that Anybody might want to look it up. It's
Sure.
hold,
So
relax,
yeah,
agony.
so it's called hold, relax, agonist, contract. So
Okay.
they're all separate words. The first part of the stretch is the hold, relax. The second part is the agonist, contract. Now, the most effective way is to join them both up. If you can't do one or the other, you just either do a hold, relax stretch or you do an agonist, contract stretch. So you do half of it. What we know is that either way, you get neurological inhibition of the muscle you want to stretch. But if you could combine both theories, you get the most amount of lengthening. Bruce, what he was mentioning was completely correct with regards to the right-sided inattention. We call it what's called anosognosia is the technical term for it. What I can see is it your left side that's affected. Yeah, I mean,
Correct. Correct.
yeah. So what I can see already in the video is the correct kind of posturing and positioning of the limb. Especially, with your functionally, you're kind of putting your hand to your face, how you naturally would do. There's no overpressure, there's no drift. So what it would say to me is it's less that you're neglectful because you understand that that side is there and that it's
Mhm.
present in its spatial orientation. But what you don't have is the actual, what we call somatosensory awareness. So you
Mhm.
don't actually have the tactility from that limb, the pain perception, the pressure perception, the touch perception. So it's very true. Both types, we want to try and encourage greater awareness of that. You've fortunately got the less complicated version of that because you actually acknowledge existence of that side, and it's much harder when we've got people that can't identify that side as their own. That becomes an even bigger challenge. But yeah, using that visual cue is going to be really helpful. And doing what Bruce said as well, if it does help in any way to get awareness of that side, trying things maybe like not excessive temperature changes, but maybe like a cool pack on that side, see if you can sense it. You could try vibrational therapy, so you can get like a little massage vibration device and place it on that limb. Try and explore the different sensory avenues to see if you can perceive anything that you could then utilize for feedback to know what's going on with that limb. So
Okay.
yeah,
I
um,
have a hairbrush. I heard of brushing from a gal. But I do have one of the little vibrators for all my
yeah,
fingers and that they gave me in occupational therapy.
good. I mean, what we know is that so what we they used to one of the very first concepts of movement recovery was by a physician called Margaret Rood, ROOD. And she was the first to discover that what we call exteroceptive, so feedback that comes from the outside. So that's like cold, temperature, touch, pressure, it will evoke some kind of sensory motor response. And there's different avenues. Brushing was one of them. Tapping was another. Light compression, load distraction, things like that were used, and they're still used today. What we know is they're strategies that if you just use that, you can't just brush a hemiplegic limb and expect recovery, for example. But what we know is
Right.
that it's a useful extra bit of sensory input that will promote greater improvement when you are then doing a well-evidenced technique such as the stretching.
Great. Thank you.
Brill. So that was range of movement. So addressing that is what the first key step. The second thing that I wanted to discuss is what's called movement synergies. Now, this is I wouldn't call this a controversial thing, but you have two competing theories here. One theory, neurodevelopmental theory, says that we should always, from step one, we should inhibit anything that's abnormal about movement that results in our limbs following some neurological problem. Um, Meanwhile, there's another theory called Brunnstrom, which says that we should utilize abnormal movement when it first emerges as a gateway to regaining some control that we can later inhibit. I tend to subscribe to the second version initially. And the best way of thinking of this is that if you've got someone with a leg or with, let's say, an arm, Bobath would say, what we're going to do is practice functional tasks immediately. So we're going to put a cup of water and we're going to practice reaching for that cup and bringing it to our mouth to have a drink. Now, there's nothing wrong with that from a theory point of view. You're doing, while the therapist guides you through that movement, they try to inhibit any tone or abnormal patterns, and they try and encourage and facilitate any voluntary movement that emerges. The issue with that approach is that a lot of people following strokes, they have complete weakness. Not everyone, but they have total weakness down one side. And what we find is that practicing voluntary movements, what's called selective movement from the get-go, is expecting too much of a nervous system that is unable to access that area despite facilitation. What we do know is that when we have these strokes, brain injuries, anything like that, we do naturally, without any therapy intervention, often start to see the emergence of simple movement synergies as part of our recovery. You might have experienced things where your hand suddenly starts to be able to tighten, or you're able to pull your arm slightly across your waist, or in the leg, you're able to just gently lock the knee against the bed. What we know is that with most strokes, that movement is very predictable in how it comes. So we know that our upper limb, our arm, tends to become flexed and develop basic flexion synergies, which manifests as the classic kind of, I call it the maitre d' posture, but that's just how I call it, where kind of you got the hand across your body with the palm flexed. Almost like, you've got a towel over and you're a waiter going to a table or whatever. Yeah. And then exactly like what Ralph's demonstrating there. And then with the lower limb, we tend to have more of a pointed leg where it straightens and curls inwards. Now that is because of this imbalance of control from the brain. Think of it like a puppeteer and a puppet, where your brain is the puppeteer and your body is the puppet. And when you have a stroke, certain strings of that puppeteer, they get cut. Other strings remain. And those strings that remain tend to become more dominant, and they just happen to only work limbs in very certain ways, which is why we get these predictable movement recovery patterns. Now, when it applies to walking, what's important is to understand that if we can try to work into those patterns and encourage voluntary control with them, then we will start to be able to unlock more movement through our walking ability. So if we're able to activate an element of knee extension when we're on the bed, for example, then we can practice and repeat that to develop conscious awareness of it, so that when we stand, we've got a better ability to engage that muscle so that we can lock and support our own weight. When it comes to synergies with our upper body, the flexion synergy, whilst we do want to inhibit it eventually, when we're first learning to walk, and maybe we're doing aided walking of some kind, having the ability to posturally support through the upper body is going to support our ability to de-weight our legs and then encourage practice. So whilst it may have been told to you a lot to never do things that are abnormal in the early phases of stroke recovery, this mainly applies to exposing and using those abnormal patterns will make them more voluntary or semi-voluntary, and that can be your gateway into opening up more movement in the future. That's the important principle there. For chronic strokes, it's more the opposite is true. So this is the distinction. When we're early on and we've got a flaccid limb and we're first starting to get these synergies, we want to use them, exploit them, do it over and over again. That's what Brunnstrom would say. And then we gradually reduce the input of them and make movement more voluntary. When we're chronic and we already have that initial phase of rapid neuroplasticity, we start to get set in our functional patterns of movement. And what we really want to do then is more move away from them and take that traditional developmental approach and inhibit them as best as we can. So it's not necessarily as much of a practical advice, it's more just a guiding principle based on what stage of stroke recovery you're at, of what you should try to do with abnormal patterns. If you're early on, allow them, facilitate them, and practice. If you're chronic, work to inhibit them and work on what is more considered normal in terms of a gait pattern. So yeah, it's not a specific example, but does that kind of principle chime with anyone here about how movement naturally recovers post-stroke? Um, do any of you experience those posturing type movements, or have any questions about why that happens, or what we can do to move past it?
I always fought against what I couldn't do. So that seems almost like you're talking about two different approaches at two different stages. I just figured if I couldn't do something, couldn't move it, couldn't stretch it, couldn't connect, I would just try to make the connections and make the movement and fight against it all the time. That was just another one of the things that I just, I don't know if I figured it out. It just, that was what I ended up doing in my recovery. I don't know if that's right or not.
Yeah, no, it's 100% right. It's you still do that. That's a really important principle. It's just that if you notice that you've got some patterns that are now present, that are not under your control. For example, the arm curling across when you stand up, or the leg going into more of a spastic support, then not to worry about that too much during the early phases, because they can be utilized so that when you practice alongside the involuntary act of that movement coming in, it's easier for your brain because it's sensing the muscle tension from the abnormal movement. And when you then try to voluntary, what we call superimposition it, you get this better neuroplastic recovery of that pattern. And then once you can voluntarily control an abnormal pattern, what we then know is the brain is really good at then mirroring and reversing it to then get the other side working. So it's just that that's more of a modern development in this therapy approach, where we kind of went from um, facilitate at all costs, which is kind of rude, and then we went into this Bobath system where it was everything abnormal, inhibit from day one. And then we have the Brunnstrom system that develops on the same time. And then we started to realize, well, Bobath is great for kind of your later stage stroke patients, or those stroke patients that don't have complete weakness down one side. Meanwhile, Brunnstrom is pretty damn good for patients that are very, very densely weak, and at the start of their recovery. So it's kind of like not a one size fits all. The principle of number two here is that dependent on where you are with your stroke recovery will determine your relationship with abnormal movement.
Well, I saw
Well,
somebody with their arm pinned against their chest, and I said, that's not going to happen to me. So I tried to break those patterns. I was pretty lucky. I didn't have a pointy toe, or I had some spasticity in my leg. I had it more in my arm, and but it didn't cross my chest. I mostly had it in my wrists and hands, and
Yeah.
I wasn't doing this. I was more doing, well, let's get the shoulder in there, the hiked shoulder and the arm that's not straight. So it was maybe easier for me than somebody with um, more who's showing more of those stroke patterns with more spasticity.
Yeah, exactly.
Spasticity, the bigger.
May I ask you what sort of time, is there a time frame that you usually view, initial and after, or are you just looking for the clues within our body and how we're working to sort of determine what's initial and
Yeah.
what's I-
What I might say, and I will give my view of things, and that's based on the evidence I I didn't write the evidence I've read, and anecdotal experience. So they're quite, this is quite a weak form of evidence base I'm giving you for my answer. Bruce probably has a much more up-to-date view of this from being a professor in neurology. Um, but what I've always been aware of is the greatest amount of neuroplastic benefit for regaining movement occurs within the first optimal at about 8 weeks, and then can run at a good level for up to 3-4 months, and then will taper off towards a year. So what I typically find is a year post stroke, it's much harder for you to regain new movement, but it's much better for still learning a skill and for developing posture and movement patterns with what you have. That's the best way of I can phrase it. I don't know whether Bruce knows anything else. If you want to chime in, Bruce.
Well, I can say a little, again, I've got no clinical experience. So, uh, but from what I've read and what I've understood with my own recovery from stroke, um, first, I did learn at one time all of the 7 Brunnstrom stages, and uh, the first Brunnstrom stage is when the affected muscles become flaccid or very loose.
Yeah.
And for me, that was very annoying because I had a subluxed left shoulder. It was very painful to move and was very loose. And then in the second Brunnstrom stage, spasticity sets in. And everybody, including me, hates spasticity, but it did help my shoulder because in spasticity, the muscles tighten. And that helped my left shoulder enormously, and I could begin to do useful exercises with the left shoulder. Now, there are a series, as I say, of 7 stages. The second stage, spasticity sets in, then it gets worse or stronger, and then stronger, and then it begins to loosen. But it doesn't just happen automatically. You sort of have to work with exercises to get through those stages. And in terms of a time frame, it really depends on how much exercise you're willing to put in. And this is true for the legs as well as the arms. And in terms of spasticity tends to mainly increase muscle tone in the anti-gravity muscles. That is, those muscles that counteract the effects of gravity. So gravity tends to pull your arms down, straighten them out, and your fingers out. So the anti-gravity muscles are your flexor muscles. That's why when spasticity sets in and it's very severe, you'll have a clenched fist and your arm may be up against your chest. The anti-gravity muscles are extremely tense. To get through that, you have to either actively or passively move them, because the ultimate goal, if we look at Edward Taub's model and the general understanding of the nervous system, is to increase the representation in your motor cortex, that's in the back of the frontal lobe in your brain. You've got your body is drawn out there. You've got sort of a whole picture of your body. It's called an homunculus, which basically means little man. It's sort of drawn out there. And the better able you are to control a body part, the larger that body part is in that little map. So naturally, if you never had a stroke, your hand and fingers would be very large in your motor cortex. And your face, in particular, your mouth, would be very large. You have large hands and a large face. Now, when stroke affects your hand and arm areas of the brain are going to diminish, so they cannot control the muscles as well. And if it affects your face, that side of the face will droop and so on. But the goal, again, according to Edward Taub, who's at the University of Alabama at Birmingham, he developed constraint-induced movement therapy. The idea is to use the affected body part as much as possible in what is called massed practice that is continuous. For example, if you say you're going to exercise your affected arm 4 hours a day, you could do it every day from 8 in the morning until noon, or you can do it from 8 to 9 in the morning, 10 to 11, then 1 to 2 in the afternoon, and 3 to 4 in the afternoon. Both of those are 4 hours a day. According to Dr. Taub, you're going to get much more recovery with the massed practice, that is 8 a.m. till noon, you'll have much more recovery than if you space it out. But he did stress that the more you use the more you use the affected limb, the better off you are. And
That's probably a better way to exercise anyway, just from a pure fatigue standpoint.
Yeah.
well,
Not everybody can do 4 hours right out of the gate, but
Exactly.
the concept is the same.
Yeah, and a constraint-induced movement therapy that Bruce is on about, it has its place. It has what's called clinically we use an eligibility criteria for it, because you have to at least have some level of control of a limb in order for it to be proven effective. We can't do it on a completely flaccid limb or a completely spastic limb. It has to have some level of voluntary control because the idea is to improve that cortical representation through force, through learned use effectively. Is there's still got to be a link between the motor cortex and the affected limb in order for it to work. But just going back to the original point of how long, every stroke is very different. Every um, person has unique factors that can determine how well they are going to recover. Obviously, we all want motivation to do better, but we all know of people, and we can't avoid this fact, that are incredibly motivated and will do every single thing imaginable and just simply don't improve. Um, and that is a lot of it is it's not always 100% in your control. There are just biological factors that limit how well your brain can recover. With things such as we can't control, age, genetics, the size, severity, and location of the lesion, of the stroke. And then you've got the modifiable factors that could have occurred during your life that determine, cortical healthiness, things, alcohol, drugs, smoking, weight, cholesterol, diabetes, all that sort of stuff. So when it says how long is it going to take for things to get better, well, it's not just one factor. It's so multifactorial that we just have to say it's unique for everybody. But on the law of averages, we say the most recovery occurs within that first 6 months, some ongoing recovery up to a year in terms of new movement. And then you learn new skills after that. Because, for example, if you put me, I always use the example of tennis. If you put me playing Roger Federer now, or even his prime, I'm going to lose 100% of the time. That doesn't mean that I've got a disability, a physical problem. It just means my brain's not learned that skill. You're in the same position where even after a year, if you can't regain new movement, your brain has still got the capacity to learn new skills with what you've got. So practice will still enable you to do something better that you once couldn't do. You just might have to, on the spectrum of quality on one side of the scale, as in fully normal movement, and on the other side, performance, which is completing the task despite allowing abnormal movement, you might just have to let the pendulum shift the longer it goes in time, where you're striving less for 100% quality and more of a balance between quality and performance, where if you have to tolerate some abnormal movement, fine, because if that still enables you to complete a task functionally, and that enables you to have an improved independence and quality of life, then surely that should be the goal that you're striving for more than how, quote, pretty you're moving.
Polly has a question.
Hi, Polly.
I am the poster child for put in the work again and again and again and am not seeing the results. And I go and, really do this work. And then I see people, just their recovery just blows right past me. And I actually asked my physical therapist last month, and I said, because I do wonder, am I holding myself back? Is it something I'm doing or not doing that's keeping me from progressing? And she said, no, you're doing everything you need to do. It's like you were just saying, it's just, maybe the severity of the stroke. And any ideas? I would dearly love to be able to walk better.
Yeah.
And I mean, I have done everything. Injections and surgery, FES, transcutaneous spinal cord stimulation, and and that goes with doing personal training every single week and skilled therapy whenever I can get it.
Yeah. I mean, the first thing I would say is you are doing everything. You've tried everything. You're trying everything to as best as possible to maximize your opportunities to recover. What I could sense at the start of that was there's a level of exhaustion with it. There's a level of frustration, obviously, with all of this process. And the important thing to just add is to not blame your lack of self-motivation as one of the factors for this. Because you said to me, is it something I'm not doing? To me, the way you phrase that is you're already trying to internalize, you're almost internalizing blame on yourself, the way you ask the question.
I don't know. I feel like I'm doing it, but I wonder if there's something, that I'm not doing that doesn't enable me to recover the way I see others recovering, or being able to do so much more than
Hmm.
I can do.
The short answer is no. The longer, more complicated answer is that because of all those factors that I kind of spoke about, there is it's not I wouldn't hate saying the word predetermined, but there is a predictable level of recovery that you will make based on that. And there will be a ceiling effect where your ceiling effect might be lower than someone else's. Um, and that might just be out of your control.
Well, I've
And
already
that's,
overcome that because
yeah.
in my medical record it says I will require institutional care for the rest of my
Oh,
life.
wow. No, no, I
And
don't mean a
I
ceiling
am
effect
I
from
am
the
living
outset.
in my own two-story home. I drove 50 miles for a medical appointment this morning, and tonight I'll drive 20 miles to pick up my son from the airport. So, yeah,
Yeah.
I've really far exceeded my prognosis.
Yeah, initial prognoses I never give because they're just so wild to you just
Well,
don't
this
know.
wasn't told to me, and this was after 2 months. This is what was put in
Yeah,
my,
it's
they
too
never
early.
told it to me, but they put it in the medical chart
Yeah.
that I was, living in La La Land if I thought I'd be able to return to my home.
No, the way that I've always framed prognoses is it's a proof of change that helps you to understand your prognoses. So the longer you go with rehab, the more things you achieve, the more complicated things are only left to achieve. And you will find if your progress.
Tom, you were talking about, getting burned out. Well, what I have found out is that if I stop doing and stop moving, everything tightens up like you're turning a screw and tighter and tighter. So I've got to keep moving to keep moving.
Part
Yeah.
because of
Oh,
severe spasticity, Tom, which I don't know if she mentioned that or not.
no, no. I think we were mainly discussing about kind of natural limitations, weren't we, of what we can and can't do, and that it's being certainly not being motivated is a key factor of not improving. But if you're already very, very motivated and trying everything, it's something that your limits are only then going to be predetermined by kind of how your brain is going to recover, really. But when you're talking about the spasticity element of things you're experiencing, yeah, the more you use the limb and stretch the spasticity, the more consistent it's going to remain at bay. If you do leave it, then the area of the brain that you're trying to reactivate to inhibit the spasticity is going to get lazy. And then you're going to start experiencing more of those abnormal problems. So yeah, that's something to definitely bear in mind. Ralph, where did you want to pick up with this? Because I know we've
God, I have no idea.
Well, if I could
yeah,
just comment, if I could comment for a minute, again, this is Bruce Hetzler. Again, I've got no clinical experience, but in terms of what I guess it was Stephanie or whoever was asking, your brain maintains its neuroplasticity potential as long as you're alive. From the time you're born till the day you die, your brain is neuroplastic. But as I think she said, if you stop trying to improve, you will regress. So until you're fully recovered, which may never happen, I don't think it'll ever happen.
Yeah.
If you stop trying to improve, you will get worse.
yeah.
So
I
it's
think
important to keep practicing in order to maintain what you've got.
yeah, and that's the thing that the brain can learn using the healthy tissue that it's got. So the neuroplasticity can carry on lifelong, a bit like with the example I used with me learning to play tennis. It's a form of neuroplasticity where you're learning a new set of skills that are going to get stored in your prefrontal lobe, and the circuitry will get learned to within the, the feed forward cycles within your brain, and they'll get more refined and connections will be made. Creating memories is a form of neuroplasticity in itself. So all of these things, neuroplasticity still does happen. It's just that in what it can achieve, in terms of re-establishing brand new control movement gets more limited as time goes on, and a lot of that is to do with the development of the scarring around the area that's had the stroke. So we get this phenomenon called gliosis, where the tissue that's been damaged, like if you were to, cut your skin, a scar will eventually form. The rate that that forms in your brain is much, much slower. But effectively, once there's a structural thing blocking connections, that's when it becomes much harder for the brain to rewire because it can't, the neurons can't navigate above and around it. Certain areas of supplementary tissue can be used, but then that can be limited in its recovery. So it's a case that you're going to get the biggest, fastest improvement in the first year. You'll still make improvements after, it'll just slow down a lot. But the moment you stop trying to improve, then you will either not maintain your functional level or you'll regress. And that's the important thing to understand from that point. So I
Tom,
think, yeah,
what you just said was really helpful in answering my questions because I had a thalamic hemorrhage.
okay,
And so, yes, when you're talking about brain communications, the switchboard is down. So, it's hard to even reroute because everything goes through the switchboard and it's just
yeah.
offline. So that helps.
Yeah, and I think if you really want to get to the nitty-gritty of it as well, is that the more specialized a tissue is, relative to the reduced size that the tissue is, the the harder it is for you to then re-establish recovery from that. So with the thalamus being a relatively small area of brain tissue, and with it being of what we call a nucleic nature as well, with more highly specialized cell structures, it's much harder to gain huge levels of progress as time marches on than if you had this large grey matter that can use all of its supplementary areas to develop. But based on you having a thalamic hemorrhage, it sounds like you've been doing really well considering that.
Yeah. And that was just part of it. Thalamic hemorrhage with extension into midbrain and pons, 6 millimeter midline shift, and basal ganglia infarct.
Yeah.
Yeah,
Wow.
so
Quite a complete, what we call diencephalon stroke, we'd call that, because it encompasses all of that area. But the one benefit, I suppose, is that whilst hemorrhages can typically be more fatal than ischemic strokes, they do tend to have a greater, if you survive them, which you did, they do tend to have better outcomes than the equivalent ischemic stroke. And that's mainly because a lot of the dysfunction you get during the early stages is related due to the intracranial pressure that develops from that excess blood being there, and this increased amount of what's called a cytotoxic edema that develops around the blood as well. So you get all of this added compression, which damages brain tissue, as well as having that lack of blood flow to the area of the brain that artery is originally going to. But when you start to get past that initial acute inflammation, you will get the reabsorption of some of that blood. The blood will become more fibrous and it will shrink and that will contract. So you'll get this pressure relief effect. So you get this like rebound improvement with kind of these hemorrhages that you typically don't get as
Yeah,
easily with
I never
ischemics.
had that. Nope.
In that case, that's just very unfortunate for you. You know, we've had
One
some,
more.
I particularly see a lot of intracerebral hemorrhages, intracranial hemorrhages that will be, you know, cognitively terrible. They'll be fully paralyzed on one side, and then within the space of, you know, a week, after a few weeks of nothing, they'll just suddenly start springing to life and everything will start working really well again, like unplugging a car battery and putting it back in. But it doesn't happen for everyone.
Yeah. Here's another question for you.
Yeah.
As a result of the stroke, and the location, I have a diagnosis of bradykinesia, and it's like I have a governor. I cannot move, past a certain speed no matter what. And that really, in the US, really affects my access to therapy because I don't make adequate progress, because I can't, all they're measuring is how fast you're moving, and I'm not moving any faster.
Yeah, and the thing is, though, is that why does that become the sole determinant of progress would be my question. Because what we
Well,
do with our,
that's the US insurance and
yeah, I mean, the
the
way we
clinical
do it,
practice guidelines that
yeah,
they have to, fall under for insurance approval, and it's a mess. And
sure. And there's a very similar, you know, because it's resource based, there's a very similar thing with our National Health Service. So they have to set targets for accessibility. But when in our private sector, it's not insurance based private sector, it's self-funding. So people pay, I don't know what your version of it is, but we would say out of pocket, they pay for session by session. Um, and then because of that,
that's what I do. I go to the physical therapy, and this is where Ralph met me. I go to the physical therapy clinic and do a self-pay. It's called NeuroFit, and it's neuro personal training we can use. So I get to choose what we do.
yeah, I mean, if in here, what we would do, what I do with our clients is that we assess obviously their functional ability. We set clear goals of what we're trying to aim towards, and like I say, the earlier you are in your stroke, when it comes back to this concept of movement recovery, the focus is on quality. It's on getting the best improvement that replicates normal as possible. As we start to get more consolidated symptoms that don't improve or that are quite resistant to change, then the dial can shift towards more performance of the skill, and mastering a skill using elements of gained movement and elements of abnormal movement. And then we would have to measure them in a specific way. So I know I've got a client at the moment who had a bilateral, so both side basal ganglia stroke. So he presents very much with what we would call acquired Parkinsonism. So his primary symptoms are not weakness, but they are very similar to what you described. Bradykinesia is one thing, rigidity is another, tremors, postural instability with kind of that classic stooped position that many people with Parkinson's disease tend to develop. But when we are trying to establish how we make improvements with this gentleman, it's not just as binary as an outcome of how quick he can do a timed up and go. Sure, it's a measure of something, but it's only one measure of functional progress. So he can, he's timed up and go improved significantly over 3 meters, I think from 18 seconds gradually down to 5 seconds. So we really got it down. But
Wow.
once we got to 5 seconds, it was 5 seconds for weeks on end. It was like that was as quick as he can move physically. His brain won't let him go any faster. That's it. So then you would from the model you're describing, someone would look at that and go, well, we've made no improvement in movement speed, so therefore therapy's done, right? But
Right.
what we would then do is look at, well, let's look at the walking again and let's see what parameters of walking are still at fault. Because sure, speed of movement in walking is one parameter. It's called a temporal parameter. But we would then want to look at other things like what's the spatial parameters? Is the step length still abnormal? Is the step height still abnormal? Is the cadence during turning still abnormal? And if it is, we would outcome measure against those individual factors and then try to work on those individual things to see if we can obtain meaningful progress in other ways that will still contribute to overall improvement. So then the outcome measure might shift. So it would go from a timed up and go. We might do something more like a Tonetti balance and gait assessment, or a PAS score, or we'll do a Berg balance score. So we'll pick some other physical means of measuring progress that relates to other symptoms they have that we haven't yet fully worked on, and then we can try and gain improvement that way. So the challenge for me to you would be it's less of the focus on the speed that you move and more what other aspects of movement that you might have difficulties with can you refocus on to improve around the speed.
Well, I'm doing that since I'm in the self-pay program as well, but when I'm in therapy, that is the clinical practice guidelines that everything falls under.
And you know what they're
And
called, guidelines, don't you?
I do have a diagnosis of vascular Parkinsonisms, so I know exactly what you're talking about.
Yeah, yeah. A lot of people with these basal ganglia, not all, a lot of people with lots of people with basal ganglia and thalamic strips do develop some either partial or full acquired Parkinsonism, but some don't entirely. If I remember, it was Ralph. Did you have a basal ganglia stroke? I think did you mention, or I got that wrong?
No, I had, like Dr. Hetzler, I had in my right thalamus.
Yeah, it was so it's a similar kind of region, right? So,
Yeah, it is.
but to my knowledge, you didn't develop any Parkinsonism-like symptoms. Is that right?
No.
So no, yeah. So this is the thing, Polly, is that not everyone. You're at a higher likelihood of developing Parkinsonism with thalamic, with basal ganglia based strokes, but it's not a guaranteed thing. Um, Yet again, it's just an unfortunate set of circumstances where you developed it, and like the client I spoke about has developed it. So yeah, when it comes to the walking aspect of things, if there's a symptom that's resistant to change just by nature of that's the lesion that took most of the function of that area away, it's about reevaluating all the other aspects of walking and how can we change and improve upon those things. And that enables you to maintain motivated. If you're motivated, you're more likely to adhere. If you adhere, you're more likely to improve. So that's the best way of viewing that.
Well, she's
I don't know if, oh, go ahead, Ralph,
I was
sorry.
going to say she's highly motivated and works her butt off, but um,
Yeah, I wish she could spread some of that to my clients too. That would be great. Yeah.
Have you had any experience with transcutaneous spinal cord stimulation for gait rehabilitation post?
No, because it's not something that we offer in the UK. Um, Simply because of the expense of that sort of technology, with it being a relatively new technology, and with it being something that requires a significant amount of resources for a relatively small amount of people it would work for. It's nothing that the National Health Service will they won't invest in stuff like that. And for us to access things like this on the private side, it would just price out everybody. Nobody would afford it in this country.
$400 US for a unit.
Yeah, not here. You're talking thousands for stuff like that over here.
But
can't.
I got to the clinic that I go to for physical therapy. They have seen such good response from it. They're putting it on everybody
Hmm.
to see how they respond. And I responded really well to it.
Yeah.
And it actually, one day I was just sitting and went to move my leg, and my leg just lifted in the air, and it was like it had taken away the spasticity. And then the thing we always look for is carryover. I was using it for 40 minutes in the clinic twice a week, and I would have like 48 hours carryover.
Yeah, well, that's really good.
That's really
Yeah.
so. I'm
And
excited about the possibilities for it. And Shirley Ryan in the US is doing some studies. And so hopefully it does become more widely available.
yeah, I mean, it's definitely more on the cutting edge side of technological advances. I know that the main thing that we're looking at into developing at the moment is neurorobotics. So we over here, for a very select number of clients that have got the means to pay for stuff like that, we've rented basically like walking exoskeletons for stroke patients and for spinal patients and things over here. And I've used them, I've been trained in them. They're brilliant bits of kit. Um, Likewise, they make fantastic progress for people that otherwise are not making much progress. And a lot of it as well, it unfortunately, just comes down to cost. And for us to rent one of those suits, it's a cost of £3,500, which is about $5,000 a month.
Mm-hmm.
To purchase the suit, it's $250,000. So it's these technologies do exist that are making improvements for people, but when it's such an expense as it is, the way our what we call it is called the NICE, so it's National Institute for Clinical Excellence. So they provide all the recommendations towards our government's health service of what we should fund. And when you've got and they do a cost benefit analysis on everything. So stuff like this, even if it's shown to be consistently statistically and clinically significant for patients, if the level of improvement isn't significant enough to change social care input or to change um, number of hospital appointments and the financial burden throughout someone's life, it wouldn't be considered effective enough. So
And that's the same here. It's, it's not socialized medicine, it's not universal health care, but it's just the same thing. Are you familiar with the Lokomat?
no.
Oh, it's a robotic treadmill.
No, I mean the ones that I've used is by a company called Cyberdyne.
Uh-huh.
Have you ever
I
heard of them?
didn't like the exoskeleton. I didn't like how it moved my less affected side. That didn't feel, it wasn't natural. It was really pushing me in ways. So I didn't like that. I was part of a study using the exoskeleton, but this is a treadmill that has robotic legs, and we can turn down the assistance so that I can move my right side more freely, but
Yeah,
it will help with knee flexion on the left.
yeah,
And I can use that. It's not approved for chronic stroke rehabilitation because they don't see, there's no demonstrated carryover. But I can, in the self-pay, like you were talking about in the self-pay program, I do get to use it once a week.
yeah. And I think, and this is a concept as well, is when we think about significance of benefit, um, especially in the research, you have to have a certain number of the population when you're comparing A to B for it to generate a number that would say this is significant enough. And that's yet again, it's a probabilities thing. So if something isn't statistically significant, that'll be because not enough of the people have achieved enough benefit to make that statement. But it doesn't mean that nobody's hasn't made a benefit from something in that. So that's the thing. It's just with something that's not clinically proven past the point of statistical significance, it doesn't necessarily mean it won't work for you. It's just less likely to achieve the benefits across the averages of the people that use it.
Well, for me, it's the emotional, standing up straight, walking at a normal walking speed, having my knee bend when I'm walking, because I like some of the other people, well, I have significant sensory impairment. And so I don't know how I'm moving unless I can see it. So we always have a mirror in front of the treadmill.
Yeah,
And just to see my knee bending as I'm walking in a normal cadence, that is so emotionally beneficial, even if
yeah.
there's no carryover off of the treadmill.
Yeah, and actually, that was one of my points. Although we've gone on to this kind of more advanced technological assistance, which actually wasn't one of my points, just because it was more, just because it was more down to everyday, you know, what people have got access to, regardless of their financial situation. Which is actually quite a social way of thinking about it, isn't it? Which is strange for someone who runs a private business, but there we go. But what we would say is that, like I say, other than range of movement, the synergies of knowing when something is useful and when abnormal movement isn't. The next point was what we call exteroceptive inputs, which is things like recording yourself walking, so filming yourself walking, um, being able to slow play that and go through it with somebody that understands gait and that can analyze movement so that you can gain an increased awareness of what needs to be improved. Because, like you mentioned, and like what I can't remember, was it Stephanie from earlier mentioned, is that with sensory impairment, you're not going to be able to intrinsically understand what's happening with your walking just by trying to listen to your body and the movement because it's impaired. So the view you'll get of it is not going to be correct. So filming gait and then watching it back to analyze, then attempting something whilst filming, whilst you're doing something different to improve upon it, and then comparing. That is another really important aspect of gait practice when you are trying to walk. And that's embedded in the concept of loosely embedded in what's called mirror therapy and in movement science technologies. That's sorry, movement science approach. That concept is where you're using feedback from what you can see and what you've attempted to link better in your brain what is making a positive change and what isn't, because sometimes just sensing it is not enough. So that's one way of doing it is film. Another way of doing it is mirrors. So being able to then view yourself. Another way we can do it is biofeedback, is what we would call it. So um, some people will use pressure sensors that they can step on, and it will help indicate when they're transferring significant weight left to right. And it kind of has like little light LEDs on it, so you can see when you're walking if it's been an identified problem for you, which is, well, I feel like I walk okay, but I don't transfer my weight onto my effective side because I don't trust it. For example, that's a common thing we have, even if there is significant supportive tone and muscle action. So sometimes the film can help, the mirror can help, where if you were to put like a line down the middle, like a vertical midline, so you can perceive when you're leaning significantly over, or if that's not enough, the biofeedback where you see these lights. Some people have even known to use I can't remember if they do it now, like the Nintendo Wii balance board thing has a similar thing built into it. But you can purchase all manner of them. Not advocating you go out and buy a Nintendo Wii, but what you can do from that is analyze and see when you're loading, and if that was the problem in your gait, you're using that feedback to understand when you are doing it sufficiently. And then your brain, if it can't listen to your leg, when it sees the lights and it registers, oh, I'm now shifting my weight enough, it will learn to interpret your position not just on where your leg is, because it can't understand that very well, but on the way that your vision changed, on the way that your inner ear adjusted to create that weight shift. And it will then remap itself to say, right, well, I know I've shifted enough weight because I sense my inner ear position go this far, and by proxy that means I've shifted enough onto my leg. So that's a good biofeedback's another really good way of improving. It's like a little trick as well, which is useful. The other concept to move on to was the idea of early mobilizing. So as soon as you can try to walk with assistance, this is for more acute strokes, the earlier you can do it, even if it requires significant support of other people, the better outcomes we're going to get. And also for chronic strokes, the more that we can, and this is as long as we can do it safely and it's able, the more that with appropriate safety measures such as people around, the walking aids that we need or whatever, the more you can adopt a speed of walking, and I know this might not apply to you, Polly, with the bradykinesia, but the more that any of us can adopt a speed of walking that better represents normal, the more likely you are to see activity emerge in your affected side. And that's on this concept of what's called central pattern generating. So what we do know is that when you or I move, the bit of our brain that wants us to walk initiates, and it targets a part of your brainstem that sets off a loop of signals. That means that you just pattern the movement without thinking about it. So, prior to your stroke, how often would you have to physically think about walking? You see where you want to go and you just go. You don't think about all of the movements that happen. It's completely autonomous. And that's because you have these circuitries between your brainstem and your spinal cord that just loop themselves. But the initiation of that often relies on matching the parameters of walking that you need to do. So the more you can get up to a normal speed of walking, whether that's via a treadmill format or whether it's via physical assistance from someone around you, the more likely you're going to turn on a central pattern generator and then unmask some movement that you can become aware of, and that will then help you to build more control over it. So that's another little tip during your rehab sessions, if you can do that. And the last one, and that Ralph will always testify to this, is the idea of repetition. It always comes back to repetition. Once you have done all of these approaches of range of movement, knowing what abnormal patterns to accept, knowing what ones you're not going to, using mirrors, biofeedback, film, verbal prompting, achieving central pattern activation. Once you've enacted those principles and you can see that you've done something meaningful that has made a positive impact on your walking, you need to consolidate it with lots and lots of repetition, as boring as it might sound, because carryover is dependent on synapses in your brain becoming strengthened to the new skill that you're learning. And in order to, at a cellular level, for your synapses to lock in place for that new skill, you need to repetitively stimulate those pathways, and that's what's going to help make the meaningful change. So if you've achieved something and you've seen a meaningful difference, you need to continue to practice that skill until it becomes a skill that you don't have to think about as much.
I'll testify about repetitions. I think they worked with me, and I've always tried to encourage people that I've worked with in person and people that I talk to that repetitions are key. But there's a lot more going on here, like where your stroke was. Polly described some things that a lot of people that she deals with that a lot of people don't deal with. So it's not like a hospital, Johnny. There's not like one size fits all,
Yeah, and
recovery.
that's the difficulty with strokes, is there are certain ones that are similar, but there are a great many that are very variable compared to the mainstream. I call them, you've got your mainstream strokes, and then you've got your less common strokes, and you'll be surprised how many less common strokes there are.
Well, no, I'll take your word for it. You see more stroke survivors than, well, all physical therapists do, but I mean, you see more stroke survivors than most people, than all the rest of us stroke survivors see others. We interact, but I mean, you're working with them, analyzing gait, getting arms moving again, whatever their issues are. So I'll more than take your anecdotal word for it.
Thank you, Ralph. I mean, I guess, is there any other questions you want to ask me about any of those principles we've been through, or anything that speaks to you as an individual that this might not apply to, and you maybe want some more information about?
I don't. Anybody else is welcome to. I'm glad Polly got to ask some of the questions about the issues of things that she deals with. I was hoping that was going to happen, and so it did. Did you see that attaboy I sent you from somebody, one of your clients?
Yeah, I recognize who that was actually. Yeah, it's surprising that when you get, a few of your clients that are on these kind of stroke buddies groups and stuff, because I've had people that have contacted me and they say that they've recognized me from doing these sorts of things, which it doesn't happen uh, massively, but yeah. But I know that lady's is a
Yeah, there's
daughter
always,
of a patient that I see. Yeah.
she said lovely things about you and getting her mom moving again when NHS couldn't.
Yeah, well, her mom is she had a hemorrhagic stroke that was in the parietal occipital region. So her primary deficit is that she's got good movement down the left-hand side, but based on what Bruce said before, she's got inattentiveness to the left. She can't feel it either, and she's got blindness to the left as well.
eyes.
Yeah, yeah, and then to on top of that, because of the pressure the initial stroke created, she became aphasic, so she has all word finding problems and also has cognitive impairment as well. So there's lots of layers to that patient.
Well, there is cross-pollination going on because somebody I led into Stroke Buddies today said mutual friends. I always check that, and they were a mutual friend of yours. So
Oh, well, there you go.
somehow found out about Stroke Buddies through you doing this time. Same way.
Yeah, I mean, I don't know whether you have the Stroke Association in the US, but that's kind of our main charity that in the UK. I don't know whether it's a thing over there.
Well, and that's my cue to tell everybody out there in YouTube land, if you're in the UK, you can look Tom up and you can find all his contact information, his website and email and such in the description underneath this video. So, uh, well, I hate that we lost a lot of our audience and got hacked and all that, but you managed to get through all the points
Well,
at the end, and I'll have to figure out
how to edit?
but well, I'm just going to say we got interrupted and put the two pieces together where they make sense. So
Probably the best thing to do to make the best of a bad situation, I
I
think,
agree
Ralph.
too. Well, I appreciate you leaving and coming back and continuing to present. We
No
all
worries. I
know
mean,
it's
it's a case of helping people. So, if unpredictable things happen, we have to try and persevere. And if that isn't a principle of stroke recovery, I don't know what is.
Yeah, it's true, and I need to take this up with Zoom or figure out something where I tell people if you're not, I've noticed that a couple times it happens about 40 minutes in. So maybe what I need to do is put up a waiting room and a wall after the meeting starts. And
Yeah, that might be a really good idea, actually.
and then, well, we've, we've done it before in a smaller meeting. The problem here is when we had 60 people register. I don't know all of them. In the exercise class, I know everybody. I recognize names of people who've been there previously and the regulars and everything. So it's a lot easier to know who to let in and who not to well, it only
Yeah,
happened once, and since I had the waiting room, it hadn't happened again. They haven't even tried. But
yeah.
because I would know because they would pop up in the waiting room. But I can't have this going on in meetings. It's embarrassing to me. And I mean,
Yeah, but at no point, Ralph, did I think it was anything to do with
it,
you or your ability or whatever. It was just
it's done. I'm not going to beat myself up over. I'm going to fix it. You
yeah,
know,
of course.
like
Yeah,
like
yeah,
anything else. A lot like stroke recovery. Don't beat yourself over it. Just keep working on it.
yeah.
On making it better.
Well, we came back, we finished.
Yeah. Well, so I know it's late for you, 10:40. So
10:40. Yes, it's about time that I was gonna say have another coffee, but you'll all think I'm mad if I say that. But yeah.
Well, and, you can never, I did Zoom the other night till 2:45 in the morning. I couldn't get to sleep until 4 o'clock in the morning because, you're wound up. It's not
Oh,
like
I don't know. I'm usually up at this time, Ralph. I'm a night owl. I'm
usually
up.
not up at
I'm
4 o'clock in the morning. But the point is, when you're presenting like this and such, it's not like you can go lay down and go to sleep. You got to wind down. So,
yeah. I don't know how I'm gonna go about doing that now, to be honest with you.
well,
Something on Netflix, I imagine. Yeah.
I have faith in you that you'll figure it out.
Yeah, definitely.
Well, thank you again.
No worries. Any time. Like I say, I love doing these sorts of things every now and again. I think it's
Okay, well, I hope they
I like
benefit you and that you can, when I get the recording on YouTube without all that crap, that, you can use it and share it, and it's beneficial to you. It's certainly beneficial to us.
well,
And
that's all that matters to me. So if anyone's got a benefit of it, then it's worth me doing. So yeah,
that's a great attitude and we appreciate it.
you're welcome.